Very happy good afternoon. Uh, we have completed the playlist for the ECG, short clips and the videos. Now we are coming back towards the topics which were having a discussion before that, and that is the cardiogenic shock part 3, wherein we'll talk about the pathophysiology of the cardiogenic shock. And after these, there will be videos about the acute pancreatitis and hypertension and the fluid management in the intensive care unit. And at the end of the video, please like the video, share the video, subscribe the channel, and also press the bell icon. Because in this video, we will talk about the pathophysiology of the cardiogenic shock. Now, it's a combination of the physiology and pathology. So, the one which is coming after the pathology is the physiology, and we should discuss it before pathology. What happens normally in the heart, that the left ventricle matters the most when it comes to the contraction, systole, or throwing of the blood from the heart to the rest of the body. And we estimate that power with the help of the ejection fraction, which is abbreviated as EF. Now, what is ejection fraction? This is the fraction of the blood which had already come into the left ventricle, and that fraction is thrown to the rest of the body. It shows the power of the left ventricle, or the power of the heart, or the ability of the heart to throw the blood which was sent to it from the body through the venous system. So at the how it is measured, the ejection fraction, which is normally should be more than 55% in all the adult patients. This is measured with the help of the stroke volume and the end diastolic volume. What is stroke volume? Stroke volume is the volume of the blood which is ejected from the heart, mainly from the left ventricle, with each single beat. Now, this stroke volume is a part of the cardiac output calculations, where we multiply the stroke volume with the heart rate, and this gives us the cardiac output in 1 minute. So, when we divide the stroke volume by the end diastolic volume, what is end diastolic volume? EDV, or end diastolic volume, is the volume of the blood which is present in the left ventricle, especially or the ventricles at the end of the diastole. Now, the ejection fraction is the percentage of that very blood which is thrown to the rest of the body, which is represented by the stroke volume. So, the measurement of the ejection fraction is stroke volume, which is divided by the end diastolic volume, and it is calculated in the percentage. And normally it should be in all the adults patient more than 55%. If we look diagrammatically the physiology of the heart, what happens that the blood from the upper arms and the head area, it is venous blood is brought down through the superior vena cava, and the blood from the GIT tract, urinary tract, and the lower limbs, it is brought towards the heart through the inferior vena cava. Now, superior vena cava, it along with the inferior vena cava, it carries the blood towards the right atrium, and from the right atrium, this deoxygenated blood enters into the right ventricle through the tricuspid valve. From here, through the pulmonary artery, this blood is brought towards the lungs, where it's oxygenated, and goes back towards the left atrium through the pulmonary vein. From the left atrium, it enters into the left ventricle through the mitral valve, and the left ventricle, it contracts. Now, this is the interventricular septum. Now, the left ventricle, it contracts, and it throws the blood through this aorta to the rest of the body, and the blood which comes from the lungs through the pulmonary vein and then into the left atrium, and ultimately ends up in the left ventricle. Then at the end of that relaxation phase of the left ventricle, or the diastole, that amount of the blood is known as the end diastolic volume. And with each beat, the proportion of the blood, the part of the blood which is thrown by the left ventricle through the aorta to the rest of the body, is known as the stroke volume. And when we divide this stroke volume by the end diastolic volume, it gives us the ejection fraction, which is in the percentage. If we talk about the pathology component of the pathophysiology, now there are certain changes in this whole physiology which can affect the functioning of the myocardium, or functioning of the heart, which was namely the cardiac output and the stroke volume. What are those factors? These are the myocardial infarction. Myo mean muscle, cardial mean heart, and infarction mean death. So whenever there is a death of the myocardium as a result of the ischemia, then it will affect the normal physiology of the heart, namely the pumping of the heart. Both the right and the left ventricular MI or the myocardial infarction is important, but most important is the left ventricle, because that is the one which contributes the most in the functioning of the heart. Our ejection fraction contribution has got the maximum part from the left ventricle. Then as a result of myocardial infarction, sometime there will be the rupture of the interventricular septum. Because of that, there will be mixing of both oxygenated and deoxygenated blood, and that will also effectively compromise the functioning of the heart. Because what does the heart do? It throws the oxygenated blood to the rest of the blood. Now just imagine if the very same ventricle is throwing normally, but it is throwing that mixed oxygenated and deoxygenated blood to the rest of the body. The tissues will be waiting for the oxygen, but when the blood arrives there, it not only contains the oxygenated blood but also the deoxygenated blood. So there will be compromise on the quality of the functioning of the heart. And as a result of the myocardial infarction, sometime also there is a rupture of the papillary muscle, which through the chorda tendineae hold the mitral valves. So when valves are not properly closing, again what happens when the left ventricle tries to throw the blood towards the aorta, it also goes back towards the left atrium and does not take part in normal functioning of the heart. So all of these things actually affect the normal physiology of the heart, which hugely contributes in the development of the cardiogenic shock. At this diagram, you see that the three major factors which affect the pathophysiology of the heart and ultimately leads to the cardiogenic shock. These are, there can be a dead myocardium because of the myocardial infarction. A part of the myocardium may be in majority of the cases in the left ventricle, but it can also be the right ventricular infarction. This part of the myocardium which is dead, this is no more contributing to the power which is generated by the left ventricle to throw the blood to the rest of the body. The greater the part of the myocardium which is dead or infarcted, the larger the chances of developing the cardiogenic shock. Now other than this, now look at here, these are the papillary muscle, these are the chorda tendineae, and they are holding on to the papillary muscle for the normal functioning of it. Whenever there is a rupture of the papillary muscle, they will no more be holding it properly, so there will be improper closing of the mitral valve, and there will be mitral valve regurgitation, and it will hugely contribute to the development of the cardiogenic shock and to the pathophysiology of the cardiogenic shock. Lastly, if you look at this septum, if there is a rupture of the septum, then there will be a mixing of the blood into, from the right ventricle and the left ventricle. So oxygenated and deoxygenated blood will be accumulating, and if a lot of deoxygenated blood from the right ventricle is coming towards the left ventricle, and that is thrown to the rest of the body as a result of normal power of the left ventricle, it will be a compromise in the functioning of the heart then, and ultimately it will also lead to the cardiogenic shock. Now, there is a very interesting phenomena which is happening in those patients who have developed the myocardial infarction. Now, the question arises how the heart cheats the ongoing cardiac ischemia. When there is a cardiac ischemia and we say that there is a death of the myocardium, but the myocardium does not die all at once, but some part of the myocardium, they try to cheat the ongoing cardiac ischemia. They show as if they are dead, but they are not actually dead. They are dysfunctional at that time, but they are alive. We have got two manifestation of this cheating to the cardiac ischemia. One is known as the myocardial stunning, and one is the myocardial hibernation. Now the what happens in myocardial stunning, part of the myocardium is alive but is not functioning well right after the ischemia. It stays silent even after reperfusion therapy has been given in the form of the thrombolytic agent or PCI, and this way it keeps on contributing in the development of the shock, because it's dysfunctional. Though it is alive, but it is dysfunctional for the time being. Ultimately, it will resolve after many more months, but it keeps on responding to inotropic support like the dopamine and dobutamine. What does that mean? That when the cardiac ischemia has happened and the myocardial stunned part of the heart is not responding to the reperfusion therapy and is not contributing to the ejection fraction, but is actually dysfunctional and is contributing to the development of the shock, And if you at that time, if you put the patient on the dopamine or dobutamine, which are a therapy for the cardiogenic shock, then that part of the myocardium which we are calling the myocardial stunned area will respond to the inotropic spot. This is a difference from the hibernating myocardium. And what's the difference between the other terminology, which is the myocardial hibernation? Now we have so oftenly heard about this terminology, hibernation. For example, frogs will hibernate during the extremes of the weather to avoid the damage to them. So same does the myocardium. When there is cardiac ischemia, the part of the myocardium, it mocks or it shows as if it is dead, but this is not actually a dead myocardium. Why the myocardium behaves this way? Because the part of the heart wants to limit further damage as a result of hypoperfusion. So myocardial hibernation, what happens that after severe myocardial infarction, some parts of it, they are not functioning properly, but they are alive. So when they are not functioning properly or they are dysfunctional, they contribute to the development of the cardiogenic shock. But there is a very good news. Once patient has undergone revascularization therapy like thrombolytic therapy or the PCI, that part of the myocardium which was hibernating will become alive and functional properly. So it's a very good defense response of the heart to limit further damage to the heart as a result of hypoperfusion, which happens in cases of the severe myocardial infarction. So this way, if you do the ejection fraction calculation or you do the echocardiogram right after the MI, there may be a decreased ejection fraction, but if you do the same echocardiogram after patient had undergone revascularization therapy and after a week or so, you will be surprised that ejection fraction has improved. Why it happens so? Because of the role of the myocardial hibernation in limiting the damage to the heart as a result of severe cardiac ischemia. Lastly, what is happening at the cellular level? What are the events which happen as a result of the cardiogenic shock at the level of the cells? Now, the definition of the shock was the generalized hypoperfusion of the vital organs. What are those vital organs? Those are the brain, kidney, and heart. When, as a result of decreased blood supply because of the malfunctioning of the heart, low blood flow happens to the cellular level, then a very low oxygen is provided to the mitochondria. There will be anaerobic oxidation. As a result of it, instead of the formation of the pyruvic acid, there will be and ATP, there will be formation of lactic acid and ATP for the energy. So this lactic acid contributes to the increase in the hydrogen ion, pH goes down, and there happens lactic acidosis. A lot of lactic acidosis ultimately denatures protein, and that causes damage to the cell membranes, and a lot of calcium comes inside. Mitochondria and chromatin, they are damaged. Now there will be damage to the normal functioning of the cell. There will be the cellular swelling. There will be the cellular dysoxia. Not only the oxygen is low, but ultimately even if we provide them with the oxygen, there will not be the normal functioning of the heart and the other vital organs. And ultimately this will lead to the MODS, which is the multi-organ dysfunction syndrome. And the science has proven that MODS is a process of the death. If a patient goes into the MODS in which more than 2 organs are dysfunctional, then the patient is on the path of the death. The most important vital organs which are important are the brain, kidney, and the heart. When there is a hypoperfusion and these cellular events happen in the brain, then there will be decreased cortical functioning, and patient will develop the brain encephalopathy and will ultimately become drowsy and go into the coma. If there is a problem, the same problem happens with the cells of the kidneys, there will be hypoperfusion and hypoxia of the cells of the kidneys. There will be oliguria and ultimately anuria. So, and in case of the another vital organs, when which is a part of the mods phenomena, if heart is involved, there will be one worsening of the cardiogenic shock. Why? When there is a decreased blood supply to the muscle of the heart, then the heart will try to compensate it because there will be a damage to the myocardium and the stroke volume will decrease. So heart will try to compensate it by increasing its heart rate. That causes the tachycardia. Now that tachycardia will need more and more oxygen, but there is a decreased supply of oxygen. So a vicious circle starts. Low oxygen, more damage, increased heart rate requirement of the more and more oxygen, but low oxygen is provided. So there will be worsening of the deterioration of the heart function. So this is a little bit about the pathophysiology of the cardiogenic shock, which is very important for its understanding.